Hi guys, we're going to talk about chapter 12, and this is going to cover schizophrenia and schizophrenia spectrum disorder. And I'm just going to go ahead and get started here. So when we look at the clinical picture, schizophrenia affects about 1% of adults. It's characterized by psychosis, which refers to altered cognition, altered perception, and impaired ability to determine what is or is not real. 75% of those with schizophrenia develop gradually, usually presenting between 15 to 25 years of age. However, there are child onset, meaning before the age of 15, and last onset, meaning after age 40, that can be seen. But these are usually more rare. When we think about the DSM-5 criteria, patients have to have 2 or more of the following for a significant portion of time in 1 month. And that's going to be delusions, hallucinations, disorganized speech, gross disorganization or catatonia, negative symptoms, functional impairment of some kind. They'll have to have 2 of those. Continuous disturbance for at least 6 months would also be criteria that would meet that DSM-5. So when we think about the comorbidities, substance use disorder, specifically alcohol and marijuana, occur in almost half of affected individuals. About 60% of these individuals with schizophrenia use nicotine, and it's usually used as a coping mechanism for cognitive impairments or anxiety. When we think about anxiety, depression, and suicide, again, these co-occur frequently in schizophrenia. Suicide attempts are more common within that first 3 years of diagnoses. Some physical health or illness, risk of premature death is about 3 to 5 times greater than that in the general population. Polydipsia is compulsive drinking excessive fluids or water intoxication, which causes hyponatremia in these schizophrenic individuals. Contributing factors include antipsychotic medication side effects, compulsive behaviors, and even neuroendocrine abnormalities. Schizophrenia disorders are inherited. About 80% of the risk comes from genetics. There is a dopamine theory when we think about neurobiological etiologies. The dopamine theory, the first antipsychotic drug blocks the activity of dopamine 2 receptor in the brain and helps reduce those symptoms. This reduction in symptoms suggests that dopamine does play a significant role in psychosis. Other neurochemical hypotheses state that second-generation antipsychotics block serotonin, suggesting that serotonin also plays a role in schizophrenia as well. Structural abnormalities cause disruption in communication with the brain. This might be due to neurodevelopment errors. CT, MRI, PET imaging can diagnose these structural abnormalities. Some of the psychological and environmental factors that we can think about are prenatal stressors. Moms that might have an infection during pregnancy, fathers over the age of 35 at the child's conception, or children born in late winter, early spring, just have a higher incidence of schizophrenia. Some psychological stressors. Schizophrenia manifests at times of developmental and family stress. So think about beginning college, moving away to college, getting married, purchasing a home. Those are all high stress levels that could bring on schizophrenic symptoms. Other psychological stress factors might include child sexual abuse, social adversity, meaning just chronic poverty, growing up in a foreign culture, maybe some exposure to psychological trauma. Some environmental stressors might be toxins. Living in an urban area or high crime areas can also increase that risk. So schizophrenia usually progresses through predictable phases, although presenting symptoms and length of phase can vary widely. So the phases that we're going to look at are prodromal, that's at onset with mild changes; acute, which is the exacerbation of symptoms; stabilization, which is where the symptoms are diminishing and we're moving to the previous level of functioning; and then our maintenance residual phase, which is where our new baseline is now established. And let's look at each of these phases individually here. In the prodromal phase, this is where symptoms appear about a month to more than a year before that first full-blown episode of the illness. There might be very mild changes to thinking and mood. Maybe our speech and thoughts might be eccentric. Anxiety, OCD behaviors may be present. We have decreased concentration. We become more suspicious. Maybe there's some memory impairment. A lot of times these patients will come in and just say, something just doesn't feel right, or something feels strange. And again, these symptoms can appear a month to more than a year before that first episode of schizophrenia it is exposed. The next phase is our acute phase, and this is where few to mild symptoms to even many disabling symptoms start appearing. They may have hallucinations, delusions, apathy, social withdrawal, diminished affect, anhedonia, disorganized behavior, and difficulty coping. So as these symptoms worsen, symptoms that once the patient could conceal are now becoming more apparent to others. So increased support is needed. Hospitalization might be required. The third phase is our stabilization phase. This is hopefully where our symptoms are getting more under control. They're starting to diminish. We're moving towards a previous function. Our residual crisis center, staff supervised home is usually where these patients live. Symptoms are stabilizing, moving towards that new function, and they are still going to need that outpatient mental health facility. And then the last phase that we're going to talk about is that maintenance phase. Conditions have stabilized. We have a new baseline. Positive symptoms are now absent, and negative and cognitive symptoms can tend to be concerning. Hopefully they are moving more into independent living here. So we're going to take a look at some of those positive, negative, and cognitive symptoms that hopefully are being absent if they're positive, but still concerning if they are still present. So let's apply our nursing process to our schizophrenia patient, remembering that the nursing process is our framework that helps guide care. So when we think about assessment, the assessment's going to involve interviewing, and that's hopefully interviewing the patient. We're going to observe their behaviors and other clinical symptoms of the disorder. We're going to obtain information from others that might know the patient, remembering some patients will conceal or minimize lots of their symptoms. We're going to do a mental status exam, and we're definitely developing that therapeutic relationship. That's just going to help strengthen that nurse-patient communication. As far as general assessment, when we think about positive symptoms, this is the presence of something that should not be present. So we're talking about hallucinations, delusions, paranoia, disorganized thoughts, right? They have the presence of these things that should not be present. Those are positive symptoms. Negative symptoms is the absence of something that should be present. So that inability to enjoy activities, social discomfort, lack of goal-directed behaviors. We should be having some of these things and they're just not present. Cognitive symptoms is impairment in memory, attention, thinking, or problem solving. And then affective symptoms are symptoms involving our emotions and expression. So this is just a recap again of the different symptoms that we might be assessing for. So make sure you understand the difference in what a positive symptom is, a negative symptom, a cognitive symptom, and an affective symptom. All right, let's look at positive symptoms. These, again, are symptoms that are present that should not be there. So these symptoms appear early and is often what precipitates treatment. The alteration in thought or delusions, remember these are false, fixed beliefs that cannot be corrected by reasoning, and they are usually very bizarre. If we're talking about persecutory delusions, that usually entails that they believe that there is someone out there that is singling them out for harm. Referential delusions is a belief that an event or a circumstance that really has no connection to them is somehow related to them. Grandiose delusions is believing that they are very powerful or very important. Somatic delusions believe that the body is changing in some unusual way. We talked a lot about somatic last week, remembering those symptoms. So the body somehow is changing in some unusual way. And the last one is control, and that's believing that another person, a group of individuals, or some external force controls their thoughts, their feelings, and their behaviors. So this slide just gives you a little bit of a visual of those delusions. If you look at grandeur or our grandiose delusion, right? One is powerful, is very important. So remember Superman, I can fly, he's all powerful. Persecution or persecutory is one that feels like they're being singled out for harm or from making any progress by others. So if we think about Batman, who's always after Batman, the Joker, right? So the Joker is singling him out for harm or from making any progress. Somatic and control is that last one there, the belief that the body is changing in some unusual way and believes that others or external forces control their thoughts, feelings, impulses, or behaviors. So another positive symptom is disorder or distortion of thought. This is just another alteration in thought. So if we think about thought blocking, a reduction or stoppage of thought. Sometimes hallucinations can cause that interruption of thought. Thought insertion is the uncomfortable belief that someone else has inserted thoughts into their brains. Thought deletion is a belief that thoughts have been taken or are missing. Magical thinking is believing that thoughts or actions affect others' consequences. And paranoia is an irrational fear ranging from mild, which is wary, kind of guarded, to very profound. So they believe irrationally that another person is really intending on killing them, getting them, just very paranoid. So distortion of thoughts kind of fits into those categories there. And again, remember these are positive symptoms, something that's there that should not be there. So the next positive symptom, again, presence of something that's there that shouldn't be there, we can look at is alteration in speech. So associative looseness or word salad is that unconscious inability to concentrate on a single thought. It's haphazard, it's illogical thinking, where concentration is poor, and individuals really lose associations with their thoughts. So we can think about just that, again, that word salad. That's the most extreme form of associative looseness. It's a jumble of words that are meaningless to the listener. So if we read here, they're destroying too many cattle and oil just to make soap. If we need soap, when you can jump into a pool of water, and then when you go to buy your gasoline, my folks always thought they should get pop. But the best thing to get is motor oil and money. May as well go there and trade in some pop caps and tires and tractors in the garage so they can pull cars away from wrecks is what I believed in, right? Very haphazard, very illogical. Their thought process are very loosely associated with each other. The second alteration in speech that we can look at is clang association, and that involves rhyming words that have similar beginning sounds. So when I think of my dad, Brad, mad, pad, lad, sad, right? Clang associations are those rhyming or similar beginning sounds. Neologisms are words that have just meaning for the patient. It tastes skreeg because of those nerve flexes. If you can define skreeg and or nerve flexes, I might be concerned about you, right? These are words that only have meaning for the patient. And that last one is echolalia, and that's that pathological repeating of others. If you've got kids, you would understand this. So you're the nurse, Mary, come get your medication. Mary says, come get your medication, right? It's that pathological just repeating of the words that are being said. Some other abnormal speech patterns that we can think about are circumstantiality, and this might include unnecessary and often tedious details in conversation, but they eventually reach the point. Tangiality is similar to circumstantiality, but they tend to wander off topic or they go off on tangents and never really reach that point. Cognitive retardation is just a generalized slowing of thinking, which is represented by delays in responding to questions or difficulty finishing those thoughts. Pressured speech is very urgent, it's intense, and it resists comments from others. They're just going to talk right over you. They don't want to hear your comments. They have something very important to say, and they're going to say it really fast and urgently. Flight of ideas is moving rapidly from one thought to the next, and it often makes it very difficult for others to follow that conversation. And then symbolic speech uses symbols instead of direct communication. So for example, a patient might report, demons are sticking needles in me, when what they really might mean is that they're experiencing some type of sharp pain, and it's symbolized by those needles. Alteration in perception is the next positive symptom that we're going to look at, and this involves errors in how one interprets perceptions or perceives reality. The most common alteration in perception are hallucinations. Hallucinations involve perceiving a sensory experience for which there's no external stimulus that exists. Auditory is the most common. It's usually experienced by more than 60% of individuals with schizophrenia. They may be very vague sounds or they may be very clear voices. They usually come from outside the person's head. These might be single voices, they may be multiple voices, they may be very supportive and pleasant, or they may be very derogatory and frightening. What are some indications that a person is hallucinating? They might track those motions. If they're turning their head in the direction of the sound, then they're tracking that noise. So if you see that happening, that might indicate to you that they're hallucinating. You might see lips moving silently. They might be trying to converse or talk with the hallucination, so they might be moving their lips. They may be talking as if to another one when there's no one else around. You may see unexplained changes in affect. Maybe they're suddenly laughing without any apparent reason. So those would all be indications that your patient might be hallucinating. How can we help our patients attempt to cope with those auditory hallucinations? They may drown out with very loud music. They may hum, they may sing, right? That's their attempt to cope with those auditory hallucinations. Visual hallucinations is the second most common, and usually that's when they're seeing persons or things. Olfactory, gustatory, and tactile hallucinations are pretty unusual, and if they are present, they need to be investigated. Command hallucinations is a particularly disturbing symptom that directs that person to take an action. These are the ones that are scary, right? If they are commanded to jump out the window or hit that nurse, A lot of times these are frightening and usually a red flag for psychiatric emergencies. So we need to be very aware of those command hallucinations. Another alteration in perception is an illusion. These are misperceptions or misinterpretations of a real experience. Depersonalization, we talked a little bit about. Non-specific feelings of being unreal or having lost identity. And derealization is a feeling that the environment has changed, such as an object in the environment, they might be shrinking. And the last positive sign to talk about is alterations in behaviors. Change in the speed of movement and behaviors that are illogical or inappropriate. Catatonia is increase or decrease in movement, excessive movement that is purposeless. A lot of times we'll see muscular rigidity. It may be so severe that the limbs remain in whatever position that they are placed. Motor retardation is just that slow movement. Motor agitation is excited behaviors. It might include pacing, rocking. It can sometimes cause extreme exhaustion. Extreme agitation may include running out into traffic or knocking others over. Stereotyped behaviors are those repetitive behaviors that really have no purpose. Waxy flexibility is usually seen in catatonia. It's maintaining an inappropriate posture that is given. So for instance, if we raised our patient's arm up to check the lymph nodes or whatever on their armpit, then waxy flexibility would be that they would inappropriate just leave that arm up above their head for a lengthy period of time. Echoprexia is mimicking of movements. Negativism is doing the opposite of what is requested. Impaired impulse control is that inability to resist our impulses. They may interrupt group meetings, throw food that is unwanted, things like that. Gesturing or posturing are unusual expressions or postures. And then boundary impairment is that inability to sense where one's body or influence ends and another one begins, right? We all have a bubble that we like, right? Boundary impairment doesn't allow for that bubble. So this is just a recap of those positive symptoms for schizophrenia. Remember that positive symptoms are symptoms that are present that should not be there. All right, let's move into negative symptoms. So negative symptoms is the absence of something that should be present. Remember, positive symptoms, a lot of times they're very so attention-getting that they make treatment seem urgent. Negative symptoms are a serious problem because they have the absence of an essential human quality. Negative symptoms are more difficult to treat than the positive ones. And remember, if you can think about negative symptoms, they include 6 symptoms that all start with the letter A. So the first one is anhedonia. Anhedonia is that reduced ability or inability to experience pleasure in everyday life. So if you're used to getting up and going to the gym and running, or going with your friends to wherever, whatever, if you have that inability to experience any pleasure, then you have anhedonia. Avolition is a loss of motivation. They have difficulty beginning and sustaining goal-directed activities. It's very reduced in motivation or goal-directed behaviors. Asociality is a decreased desire for or comfort during social interactions. Affective blunting is reduced or constricted affect. Apathy is a decreased interest in or attention to activities or beliefs that would otherwise be interesting or important. Alogia is reduction in speech, also sometimes called poverty of speech. And then one additional A word is affect. And that affect can usually be categorized in one of four ways. This is that outward expression of a person's internal emotional state. So if they have a flat affect, it's an immobile or blank facial expression. Blunted is reduced or minimally emotional response. Inappropriate is incongruent with the actual emotional state or situation. So that might be laughing in the response of a tragedy, right? It's inappropriate. And then bizarre affect is that odd, illogical, inappropriate, or unfounded. A lot of time it's going to include just making your face kind of grimacy. All right, so the next set of symptoms we're going to talk about are cognitive symptoms. This is that third group that we talked about earlier, and these are usually evident in most schizophrenic patients. These impairments can lead to poor judgment, decreased ability to cope, learn, or manage their health. They may not be successful in school or work. Concrete thinking is an impaired ability to think abstractly, and it usually results in interpreting or perceiving things in a very literal manner. Impaired memory impacts short-term memory and that ability to learn. Impaired information processing, delayed responses, misperceptions, difficulty understanding others. They may lose the ability to screen out insignificant stimuli, which could lead to overstimulation. And then that last one is impaired executive functioning, which includes just difficulty with reasoning, setting priorities, comparing options, and placing things in logical order. These things may interfere with problem solving and can contribute to inappropriateness in our social settings. And then the last set of symptoms are affective symptoms, those that are involved with experience and expression of emotions. So their mood may be unstable, erratic, labile, which just means changing rapidly and easily, or incongruent. A serious affective change often seen in schizophrenia is depression. Assessment for depression is crucial with these patients. It may herald impending relapse. It might increase the substance abuse, increase suicide risk, and further impair functioning. So we need to be just aware that when we're looking at experience and expression of emotions, are they going down that depression rail? And we just need to be conscientious of that. All right, guys. People with schizophrenia often experience, I say this word wrong all of the time, anosognosia, which is that top side there, that inability to realize that they are ill. It's usually caused by the illness itself. It may result in resistance or cessation of treatment, and often it's combined with paranoia, so that accepting help is really impossible. So know that people with schizophrenia are going to experience this. When we're working with these individuals, it can bring a lot of anxiety or fear, maybe even frustration on our part. So we need to look at our expectations of our patient, and are they realistic? They may need to seek more effective ways of helping that patient to help, and also help that staff overcome some of those feelings of helplessness and reduced countertransference. So other assessment guidelines that we can think about, we want to ensure that our patient has a medical workup. Medical disorders are common and may affect mental status. So we want to assess for patients or for indications of medical problems that might mimic psychosis. Maybe brain trauma, drug intoxication, those might mimic some of that psychosis behaviors. We also want to make sure we're assessing for substance or alcohol use, and we're completing a full mental status examination. We want to assess for hallucinations, delusions, suicidal risk. We want to make sure we assess the ability to ensure personal safety and health. Are they getting enough food and fluids, sleep, completing self-hygiene and self-cares, assess for prescribed medications. Are they taking their meds? Are there any side effects? Are there any factors that might influence adherence? So we've done a complete assessment of our patient. So the second step in our nursing process is the analysis part. So we want to make sure we're prioritizing for positive and negative symptoms. Again, those positive symptoms might be disturbed sensory perception, risk for self-directed or other directed violence, impaired verbal communication. If they have negative symptoms present, maybe social isolation, chronic low self-esteem. Table 12.2 on page 201 in your book has a really great table that shows signs and symptoms that you may observe and with each of those nursing diagnoses. The next step in our nursing process is outcome identification. So we want to know that our outcomes need to focus on knowledge, management, coping, and quality of life. Outcomes need to be consistent with the recovery model. So if we're in phase 1, which is that acute stage, patient safety and medical stabilization is vital. Phase 2 is stabilization. We want to help our patient understand their illness and treatment, stabilize with medications, and control or cope any of those symptoms. Phase 3 is maintenance. We want to maintain and increase symptom control and insight, adhere to treatments, and prevent relapse, and increase independence and achieve satisfactory quality of life. So those are those outcomes that we can identify. So if we're in the acute phase of the illness, and we are now in our implementation part of our nursing process, 24-hour support is required to prevent self-harm or harm to others. Structure within that therapeutic milieu can provide a feeling of security for our patients. Pharmacological treatment for positive and negative symptoms, helping that patient to recognize and self-manage symptoms. Some patients in the acute phase may exhibit a risk for physical violence. And it could be just in response to those hallucinations, delusions, paranoia, or impaired judgment and impulse control. Once they have moved into the second phase, or the stabilization or maintenance phase, our interventions may look like this. Care is more geared toward the patient's strengths, culture, personal preferences, and needs. Connecting patients and families to community resources, not just referring, but truly connecting them. Communication is usually aimed to build that trust and reduce those anxiety. We need to remember that these patients have memory and attentional impairments, and they require repetition, visual and verbal reminders to help promote learning and task completion. We also need to remember that shorter, frequent counseling sessions are going to be better tolerated. When we intervene during hallucinations, we need to focus on understanding the patient's experience and responses. We need to make sure we can help that patient feel safe, and remember that the hallucinations are very, very real for that patient. And remember, those hallucinations may be supportive, they could be very terrifying, they could be very faint or quiet or very loud, episodic or consistent. Nursing cares might include calling that patient by name, speaking simply and loudly enough to be understood. Remember, during that auditory hallucination, we need to redirect the focus and be supportive. If we're intervening in the middle of a delusion, we need to acknowledge that patient's experience, convey empathy, avoid questioning the delusion, and focus on helping that patient again feel safe. If we're intervening with associative looseness, we don't want to pretend that we understand when we don't. Remember that associative looseness was all of those different speech patterns. right? If you don't understand, don't pretend that you understand. Placing the difficulty understanding on yourself and not on your patient. So for instance, you could say something like, I'm having trouble following what you are saying. Don't say something like, you're not making any sense, right? Make sure the difficulty understanding is on you, not on them. We want to look for recurring issues or themes. Those might be possible triggers. Summarize or paraphrase the patient communication to help role model clear communication. We also can give the patient an opportunity to correct any misunderstandings. When we think about health teaching and health promotion, patients and families should be included in this. We want to ensure that the education regarding the nature of the illness, what to expect, how it's treated, ways to cope, are there going to be any medications, any side effects, and resources that we can give them. Psychobiological interventions. So when we think about medications to treat schizophrenia, these are our antipsychotic medications. We can have first generation, which is halperidol, second generation, you can see those written there, and then third generation. We also have injectable antipsychotics, and those can both be short-acting and long-acting. All antipsychotics usually take 2 to 6 weeks for the desired effect. Antipsychotics are not addictive, but they should be discontinued gradually to minimize any side effects of discontinuation syndrome. A lot of times if they immediately stop them, they may have some dizziness, tremors, insomnia, anxiety type symptoms. So if we gradually discontinue them, hopefully they don't have those side effects, or it minimizes those side effects. First generation antipsychotics are those dopamine antagonists, which is our halperidol, loxapine, chlorpromazine, and fluvenazine. Sorry guys, I'm terrible with those names. These are used less frequently because of the minimal impact on negative symptoms. They generally have high side effects. They do target those positive symptoms of schizophrenia. The advantages is that they are less expensive. And then the second generation, some of the disadvantages, because they block the dopamine receptors, it can cause some extrapyramidal side effects. So when we think about extrapyramidal side effects, we can think about 4 different kind of disorders here. Parkinsonism, which is temporary symptoms that look like Parkinson's. Tremors, gait impairment, bradykinesia. Acute dystonia, which is that sudden sustained contracture of several muscle groups. It can be very frightening and painful. Akathisia is pacing, repetitive movements, or that inability to stay still. It can be severe or distressing. It can be mistaken for anxiety or agitation. And then tardive dyskinesia is probably one you might be familiar with. It can occur after prolonged treatment, and it usually often persists after the medication has been discontinued. It can vary from mild to severe. It can be very disfiguring or incapacitating, and it's generally non-reversible. So once they have these tardive dyskinesia symptoms, unfortunately, it's non-reversible. We can help eliminate some of these extrapyramidal side effects by just lowering the dose of the medication. Other disadvantages are anticholinergic side effects, weight gain, sexual dysfunction, endocrine disturbances, things like that. If you're talking to your patients about all of those different side effects or those disadvantages, and they're very like, I'm not going to gain any weight, I did so well losing all this weight, whatever, it's probably not a good idea to give them those meds because they're probably not going to adhere to them. Some of the second generational atypical antipsychotics are risperidone, olanzapine. You see them written there. This is often chosen as the first line antipsychotics because they are equally effective for both positive and negative symptoms. There's minimal to no extrapyramidal side effects or tardive dyskinesia. Some of the disadvantages that you will see are they have a tendency still to cause some significant weight gain, and there is a risk for that metabolic syndrome. Metabolic syndrome is that weight gain, especially in the abdominal area. You can see some dyslipidemia, increased blood glucose, and insulin resistance. So make sure you're just talking to your patients about the medication options and those side effects. Third generation antipsychotics are there, Abilify, Rexulti, Vraylar. Again, it's a dopamine system stabilizer. It can help improve positive and negative symptoms, maybe even some cognitive function. There's little risk of those extrapyramidal side effects or tardive dyskinesia with these. Some potentially dangerous responses to our antipsychotics. We can talk about ACH toxicity. Again, that's a potentially life-threatening medical emergency. Neuroleptic malignant syndrome can occur within first or second generation antipsychotics, and it's severe muscle rigidity, dysphagia, hypertension, tachycardia, and diaphoresis. Management for that's going to be fluid balance, and then temperature reduction. Agranulocytosis is that reduced neutrophil count. Neutropenia is possible and it can be fatal. Some symptoms that might include it in the agranulocytosis would be fever, sore throat, and chills. So if you can think about your neutropenic patients, what you don't want them to have is fever, sore throat, and chills, right? It could be fatal for them. So then the last component to our nursing process is to evaluate, right? We need to reevaluate the progress regularly and then adjust treatments if we need to. Even after symptoms improve outwardly, inside that patient is still recovering. Set small goals. Recovery does take several months, so be patient. Active ongoing communication and caring is essential. And that concludes chapter 12 on schizophrenia. It's a lengthy chapter, guys, with lots and lots of small details. So just make sure you understand. If you have any questions, we will talk a little bit about it in class. Otherwise, you can shoot me an email. Thanks, guys.